Hello, hello, everybody. Happy Saturday. Welcome to another VMR. We're getting closer and closer to the new year, and I think a lot of people are um, toning it down, relaxing for the holidays here in many parts of the Western world. But I think it's really cool to see just how global the CP Solvers community is because I think there will be more people joining VMR in this time as they have time off and manifest their obsession with clinical reasoning. And I'm delighted to share the stage with somebody who I know is also obsessed with critical reasoning, and that's Jimena, who needs no introduction. But I really, really excited to give you a brief intro to her. And I think that Jimena is the first person who um, took the pathway that we just emphasized privately to everybody. Jimena was really, really interested in presenting case after case after case in the VMR community. And it was just impossible to ignore the sheer momentum and weight of the number of cases she was presenting. But that was just honestly like a sidetrack. What we witnessed is somebody who's so dedicated to medicine, who's so passionate about it, and just loves being surrounded by medicine. And slowly but surely became a CP Solver Academy member and hasn't stopped since then. And I think what we suspected him may not became true. You have become a fundamental member of this community in such a short period of time. We're talking just single digit months. And I think it's telling actually a little bit telling about the character that you are in the two key things that you're part of behind the scenes, both initiatives that bring people together, working with Tansu and Umbish and connecting it to Academy members in general, and then working with Francisco and Noah to bring people together around their interviews and practice and mentor that process. I know that you're also beginning or are starting to work on a super, not so super secret project, but part two of another project coming up very, very soon. But I think it's just so cool to see how how much impact you've made in such a short period of time and how integral you've become to this community. And like always, we celebrate that by making you really, really, really nervous. Um, I'm curious, how do you feel compared to how you thought you'd feel?
Well, hi, hello everyone. Thank you, Ravi, for your kind words. I think that it's very hard not to get involved with CP solvers when it's just so full of really kind people and that I have really, really enjoyed working with. So it's been a pleasure just being part of this. How I feel today, I feel excited. I feel nervous. But also, I feel good because before you started recording the meeting, you said that this is like a discussion among family. And I think that you're entirely right. So I'm just going to try to focus on that and just see familiar faces there that are going to make me feel a lot better.
100%. So well said. And speaking of familiar face, Yuki, this is case presentation number three. Is that right?
I think it's my number two.
Number two. Wow. Okay. See, I'm already increasing. I'm already expecting number three. I can see it
Ah,
happening already.
thank you
Um,
so much.
do you mind telling the audience a little bit about yourself and where you're zooming from?
Okay, now I'm in Japan, and again, I'm Yuki. I'm the general internal medicine physician in Japan. Now I'm preparing for the next cycle, and and next February and March, I'll go to the US to do USC. So that's why now I'm trying to get familiarized presenting in English and switching my brain mode from Japanese mode to English one. So that's why I'm presenting today.
Amazing. We're so excited to have you. Welcome back, Yuki. And whenever you're ready, we can start to discuss your case.
Okay. The case day chief complaint was sudden vision loss in the left eye, and the patient was a 70-year-old woman with long-standing diabetes, and her history of present illness. 3 days prior, she had fatigue, fever, and anorexia. On the day of admission, she experienced sudden difficulty in seeing the left eye, prompting the ear visit.
Wow, Yuki, what an incredible start. Um, Jimena, there's a lot already to this case, but I think part of beginning to solve it in a logical manner just begins by taking it slowly and taking one piece at a time. And I think it's really hard to ignore the fact that this person has lost vision. So I'm curious, when you hear, when that's all you know about a patient, that they've had visual loss, what kinds of thoughts start to cross your mind?
Well, I think that the timing here it's very important because they're telling you that it's sudden, so it's mostly something that can happen in that way. So I immediately think about infections that can progress really quickly. I think about vascular causes, and also another thing that it's a very important is the fact that it's just in one eye. So we have to like localize that in that part. And also I like to think about like what could happen within the eye per se, or these structures that are going to make the eye see, which is in this case is the brain. So I'm just trying right now to focus on what we know and just trying to see the problem from different perspectives. If maybe that's gonna help us uh, get to the answer, particularly with this patient.
Yeah, no, I agree with you. I think that the sudden onset nature is really, really important. I'm curious if you were just to focus on the fact that it's in the left eye, what did that do for you?
I think that that makes me localize it more to the eye structures
Yeah,
per se
excellent.
and think about that first,
Mhm.
because if it would have been a problem with the brain, then we would expect or more commonly see that it would involve the two eyes.
Exactly. Yeah, precisely. I think that when you're saying that the patient has vision loss in one eye or monocular vision loss, that localizes the lesion to the eye itself or the optic nerve that is distal to the crossing in the optic chiasm. So the comprehensive differential diagnosis is the eye and the optic nerve. But Jimena, I'll share with you a practical observation, and it comes from asking how can a patient distinguish vision loss in the left eye from left visual field difficulties? And when you think about it as a layperson without training, you begin to realize that it's actually pretty hard for people to localize the left eye versus the left visual field. The only way to do that with confidence is to cover the eye and to see that the right eye is normal and the left eye is completely out, noticing that the right side of the left eye is impaired. So I would give it a 50-50% chance that when a patient says sudden loss in my left eye, that they mean strictly their left eye, and the other 50% chance that they're actually noticing a left visual field deficit. So, as you said, the first practical step is to actually start to do an exam right away. Because if you're solving an eye problem is very, very different than you solving a brain problem, fundamentally different. But I think for the sake of practice, if we were in the eye, what are some common conditions that you've either seen or heard about that can cause ocular sudden vision loss? Anything that you're familiar with? This is not a common space, so you may not have seen it, but I'm curious what you may know.
Well, I think that it's important like in the realm of glaucoma, because it can be just like so broad. Like that's one of the first things that I think about. Definitely that would be accompanied by other symptoms like pain, for example. And you can palpate the eye and see if the tone of the eye it's just harder. That would be like the first thing. Then I would like to think about the back of the eye, some type of
Excellent.
ischemia, um, then just or ischemia or thrombosis, which is can also cause that. I would also think about some problems with the nerve, compression of the nerve, neuritis.
Excellent.
Um, any type of tumor there. And at last, just like the retina detaching completely. It would be very weird for the retina to detach completely because that would cause like vision loss. Usually when it detaches, it's just like in parts.
Yeah.
So the patient refers like parts of the vision that they can see. Um, and I think that would be like the
Yeah.
main thing I would worry about.
You hit on everything, including the details, but you actually made the most important point practically, which is in about 30 seconds with a quick conversation with a patient, you can make tremendous progress. The first is monocular vision loss versus field cut. That's the first thing. The next thing is if you are in fact in the eye, trying to localize it to anterior or posterior eye is very important. The two most common causes of anterior eye issues causing visual loss are corneal diseases like keratitis or acute angle closure glaucoma. Those are universally accompanied by marked pain and a red eye. So if you look and you see the eye is red and the patient has visual loss, you're probably dealing with keratitis, acute angle closure glaucoma, or endophthalmitis. If it's in the eye and the eye is not red and not painful, it's either the retina, the optic nerve, or the vitreous by far and away. So if we assume it's in the eye, and if we take it at face value that the eye is not hurting or red, which we may be wrong, but subconsciously that's probably what we would assume, we are now in the left eye and we are in either the vitreous, the retina, or the optic nerve. And if we restrict ourselves artificially to those spaces, we have some accompanying clues. The patient has diabetes and the patient has a acute febrile syndrome. So I don't think in real life you would make progress without getting more information, but this is what practice is for, is to sort of fine tune those neurons that help you connect vitreous, retina, optic nerve with diabetes and fever. So maybe just word salad, like what kinds of associations can we begin to build that we will either dismiss or highlight going forward? So let's just start that conversation now with your reflex thoughts.
I have a question for you in this case.
Yeah.
Because obviously the diagnosis of diabetes or the history of diabetes, it's sometimes key, in patients. I'm not thinking about this being a complication of diabetes per se, because it seems like it's very acute and it's very localized. But I'm wondering if you're thinking about diabetes as an process that compromises the immunity. So we can guide that and use that like risk factor to go into that realm too.
I think that one of the things to think about is, does the patient have diabetes and have an infectious process in their eye for sure? The most common cause of acute monocular vision loss in a patient with diabetes is that diabetes is an atherosclerotic disease risk factor, and they have ipsilateral carotid disease that causes sudden vision loss through a retinal artery ischemia or optic nerve ischemia. The second most common cause is not ischemia, but the opposite, hemorrhage. And patients with diabetes can form new blood vessels in their eye, diabetic retinopathy with neovascularization. And those fragile blood vessels can bleed, causing vitreal hemorrhage. So if you're studying the overlap between diabetes and eye, the most common manifestations are the regular old atherosclerotic manifestations of diabetes, usually from the carotid flicking into the eye, either the retina or the optic nerve, and then the consequences of chronic ischemia inducing neovascularization or new blood vessels. These new blood vessels are fragile and they bleed very easily. The overlap of infection and monocular vision loss is ridiculously rare, unbelievably rare, and very, very interesting. And I probably wouldn't be thinking about it in real time until I made more progress on where the lesion is. But I will say, I won't say it now, but I want all of us to practice thinking about a condition right now that we should think about when we're ready to see these patients independently as senior attending physicians. So there's a diagnosis that whenever you hear about it, a patient who is having a patient who's over 50, who has inflammation and vision loss, we have to think about it right away. And Yusuf said it. Excellent, guys. It's giant cell arteritis. So it's a rare diagnosis, but the ER docs are trained to think about this diagnosis way out of proportion to its prevalence because of its morbidity. Um, so I love to stay anchored in what you said about the likelihood that this is in these three structures, the back of the eye, and we'll see what progress we can make. But I think we should just be honest that we've made a lot of assumptions. This could be visual field and that we're dealing with a brain problem. So we'll see what Yuki has in store for us.
Okay, in the next trial record, the level system was positive for fever, recent weakness, loss of appetite, and recent vision loss in the left eye. And the rest of the level system was negative for what I mentioned in the HPI. And her past medical history was only notable for poor adherence, long-standing diabetes. She denied any surgical history. She was on stagliptin, 5 milligram one tablet once daily. She did not have any food and drug allergies. And she denied any recreational drug use, occupational inhalation, and recent travel history.
Awesome. Thank you. Did you want to stop here?
Ah,
Up to
yeah.
you. I know you already planned this case, so whenever you want us to talk, please let us know.
Ah, okay. And she had been retired and lived with her husband, son, and grandchildren. And she drank a can of beer every day. And she was a past smoker, but she couldn't just describe the detailed history. Yeah, but she was a past smoker. Okay, I will stop here.
Amazing. Thank you, Yuki. Yeah, Jimena, I'm curious what this did for you. How are you modifying our prior conversation with the data you have?
I think that probably the one thing that would alarm us right now is the fact that she has been a smoker. That just elevates her risk for vascular problems. But honestly, I don't think that we have gotten like any more information that it's making me swing either to one side or the other with what we talked in the past.
I completely agree with you. I think that's exactly where I'm at. I'll share an observation that I don't think is evidence-based or data-driven, but is a feature of the patients that I see, which is whenever somebody comes in and I'm taking care of them and I hear that they have a chronic uncontrolled condition, I always worry a little bit about the accuracy of the HPI. Now, what do I mean by that? I mean that when patients have made a conscious decision to forego strict, tight control on their medical history, I think it's very reasonable and very possible that the same principles apply for the HPI, that there's not a strict, tight control on the sequence of events in the HPI. And why is that important? Because I think it's just so important to make sure that we really are dealing with 3 days of fever, that we really are dealing with acute vision loss. And I think the openness to a more complex story that is in part more complicated because the patient maybe does not like to seek medical care, does not like to take medications, and has been having symptoms that were previously minimized. So I think whenever I hear chronic uncontrolled condition, the the tightness of the HPI becomes a little bit more loose in my mind. And now I'm very much open to the patient having subacute vision loss accompanied by acute disease, or the patient having fever for much longer, or the patient having weight loss and not having said so. But I agree with you. The past smoking here certainly accelerates her risk for even more consequences. All right, Yuki, please tell us more.
Okay. Next, her temperature was 38.4, that's 11 Fahrenheit, and blood pressure was 170 over 100. Heart rate was 96 beats per minute regular. Respiration rate was 20 per minute, and oxygen saturation was 99% on room air. And HMT exam showed no conjunctive pallor, hemorrhage, or extras, but redness in the left eye and some dental caries were noted. Neck exam showed a supple neck, no jugular venous distension. Sorry.
Okay.
and some no cervical lymphadenopathy or goiter. Cardiac and lung exam showed regular lateral rhythm, no murmurs, larps or gallops, and clear to auscultation bilaterally, no wheezes, bronchi or crackers. Abdominal exam showed soft arm fat, no scars, hernias, no rash, no tenderness. On the back exam showed no severe tenderness and no vertebral tenderness. Extremities and the skin exam showed no rashes, no edema, no solar nodes, no gene-wide lesions, no splinter hemorrhage. And neural exam showed oriented only to place and pattern, and positive left nasal hemianopia, normal eye movement, no nystagmus, no pronator drift bilaterally, no sensory alterations, positive truncal ataxia, inoculate finger to nose test, and clumsy alternating spination and pronation test. I will stop here.
Wow, I mean, this is not the exam that I was thinking we would get. Maybe I can try to just summarize, and I mean, I give you a minute to think about it to try to just summarize the key features because I think there are a lot of them, so that you have the chance to analyze the data accurately. So Yuki, I'll just summarize. The left eye is red, and the patient has left flattening of the left nasolabial fold. And the patient also is a little confused, alert, and oriented just to self. And the patient has some cerebellar findings. Can you remind us what the ataxia and the clumsiness was one more time, please?
Yeah, she had difficulty in sitting still, so she was like
Hmm.
moving. So I thought that was ataxia, and she also had alternation when I did finger to
Yeah.
nose test.
And did she have um, impaired finger to nose on one side or both sides?
There was both sides,
Both
and
sides.
she yeah, and she also looked like confused.
Confused.
But yeah, but I was wondering, that is because of vision loss, because vision loss is so shocking. So I
I
was
see.
thinking like that.
Yeah, understood. Okay. Thank you very much. All right, Jimena, this is really tricky. I think Navpreet showed us how tricky the neuro exam can be yesterday. And so we'll do the best we can in recognizing that it's hard to make tremendous progress when you don't have a good grasp of what the neuro deficits are. But what did you make of this data?
I think that with the data that you reviewed and added that the fever and the blood pressure, those are the two things that stand out for me. Mostly the blood pressure because this patient doesn't have any history of having hypertension. And this patient doesn't seem to be in a panic attack or pain, which would be less morbid causes of a high blood pressure. So that it's making me think like either this is a problem within the brain that can be vascular or probably infectious because of the fever. That's where I'm at right now. But I'm curious to know what do you think about it?
Yeah, no, 100%. I think that's superb. I have nothing to add to that. I'm curious what you made of the neuro stuff and the redness in the left eye. What did you layer onto that?
Um, What do you mean by that?
When earlier when we were like, what's the vision loss and tracking the vision loss? I think the data that we got is we don't know what her visual fields are, but we hear that the eye is red. So if we were to say, okay, if we take on the vision loss and we add in the red eye, what does that do for you to help you understand the vision loss?
Well, that makes me think about glaucoma,
Mhm.
even if the patient doesn't have pain, but like besides that, just like high blood pressure, because we don't know like what's specifically causing that redness, if it's redness per se, or like if we are seeing some hemorrhage in the
Mhm.
sclera. So that's where I'm thinking at if it's either if it's high pressure within the eye or
Yeah,
high systemic pressure.
awesome. Yeah, you know what's really, really interesting about the hypertensive manifestations in the eye, they're very important. Whenever patients do bleed or do have hypertensive ocular manifestations, they're always in the back of the eye. And so we'll never be able to see them with our naked eye. So while you can have redness in the eye from hypertension, it's usually in the retina. And so you will not be able to see it until you do a dilated fundoscopic exam. So I think the progress you can make with the redness in the left eye is to say the redness in the left eye means that the anterior structures are involved. And those anterior structures are the cornea, the conjunctiva, the uvea, and the sclera. And so that's where you're like, okay, is it a acute angle closure glaucoma issue where these structures compress on the lens? Very, very possible. The pupillary exam and, as you said, pressing on the eye will be very, very helpful. But I think now, not only do you know for sure the eye itself is involved in the vision loss, but you know the front of the eye is involved in vision loss. And whenever you have fever, eye redness, and vision loss, the reflex is to worry about infection, and the reflex is to worry about a devastating infection of the fluid that the eye is that the fluid that is contained in the eye, the aqueous and the vitreous humor. And that infection is called endophthalmitis. Um, is that a term that it's a very rare diagnosis. Is that a term that you've heard of before, Jimena? Endophthalmitis?
I definitely heard the term before, but I have never seen a patient with that diagnosis.
Yeah, odds are, well, maybe today we'll change that, Udo. I don't know. Um, but it's rare. It's very, very rare. Most patients get endophthalmitis after cataract surgery, but you can also get it without trauma. So, as a reflex, when you hear eye is red and the patient's febrile, the scariest diagnosis to entertain is the deepest possible involvement that is still anterior, and that's involvement of the aqueous humor or the fluid in the eye. So I think we should be very confident the patient has some ocular involvement. And now we have all this neurological stuff to try to factor in. There is flattening of the left nasolabial fold, suggesting some facial nerve issues. There's some confusion, some ataxia. Well, how are you incorporating all of that?
When you mean incorporating, like where am I swinging to?
Yeah, what are you doing with that
Oh,
information? Yeah. I don't know why I'm using fancy words like incorporating. I'm not sure. Yeah. What are you doing with that information?
it's totally okay. I'm making sure that I understood well.
Yeah.
Um, but I think that right now, because at the beginning of the case, we were thinking that this was going to be a more localized process within the eye. So definitely, if this patient is having some more diffuse neurological symptoms, that's swinging
Awesome.
us to just look at the problem, uh, if the problem is within the brain, and just I think that it also makes us a little bit more concerned because there are more of a diagnosis that can't be within the brain per se than morbid diagnosis with localized lesions. So I think that just makes us worry a lot more about our patient.
Excellent articulation. I think that's exactly right. And from a practical perspective, there's no way you're not going to get a head CT on this person who has fever and confusion. But I'm paying attention on this head CT to both the brain, but also the sinuses, because the simplest way to get disease in the eye end disease in the brain is to have a disease in the sinuses go like this and go like this. And so in this patient, you want to look at their head CT very closely, not just for the brain, but also for the pericranial structures. It's going to be fundamentally important. But I think you said it so well. The presence of neurologic symptoms with ocular symptoms prioritizes a more widespread disease, increasing our concern for the severity of this illness that the patient has. So well said. All right, Yuki, tell us more, please.
Okay, how about the data? CBC showed white blood cell count 22,000, whereas 90% segmented neutrophils, hemoglobin 15, platelet count 11,000. BNP showed sodium 134, potassium 4.5, chloride 95, calcium 8.5, BUN 30, creatinine 0.9, plasma glucose 480. LFT showed AST 33, ALT 60, LDH 250, ALP 380, CK 170, total bilirubin 1.1, albumin 3.2, and her CLP was 25, and HbA1c was 10. May I proceed?
Yeah, you're presenting it so clearly and so well. Yes. Did you want to stop here or did you want to give us more information? Up to you.
So I will stop here.
Okay. All right, Jimena. Thoughts?
Um, I think that definitely that white blood count, it's pointing us to the direction that we were thinking originally. Probably there's an infection. I'm worried about the platelets. Did I hear correctly that it was 11K? Yes? Okay. So that makes me worry about the patient. Those platelets are very low. I don't know if it's a result of what the patient has or a cause, thinking that this might have been a stroke. Um, and let's see.
So sorry to interrupt you. The patient's platelet count was 111,000. So sorry.
Oh, okay. Well, that makes me not worry about that as much.
Me too. I was like, oh my gosh. Wow.
Um, LDH, yeah.
Yeah, the only other abnormality,
And then,
there's two other abnormalities. The glucose is high and the alk phos is high.
yeah.
Everything else is actually at baseline. Oh, and the A1C, sorry. Yeah.
Well, yeah, like I think that right now with the glucose, this is just
Yeah.
telling me that this patient hasn't been very well controlled. So it just increases the probability of this being of vascular origin, as we have talked in the past. Um, if she's a little bit disoriented,
Hmm.
and she is, and we're thinking that this might be an infection and she's septic, like I
Yeah.
wouldn't be so surprised of her having that glucose.
Excellent.
Um, and yeah, the 90% neutrophils, that it's also guiding us to a more infectious etiology right now.
Excellent. Superb. Yeah. I think that you were suspicious of infection before you got a fever and then you got a high white count that is neutrophilic predominant. So you have to think about infection, and it's going to take so much work for us to move beyond infection, so much more data. We're going to be so stubborn to look for the infection until we prove otherwise. That's absolutely superb. A low platelet count like this, it's not super low. I think you don't have to think beyond infection because infection will also suppress your platelet count. Um, and I think that the A1C is the marker of your average glucose for 3 months, which tells you that her average glucose has been 300 or 400 for quite some time. And then the acute glucose is higher than her average, supporting exactly what you said, that her infection is very high. So I think that we got a lot of things that just reinforce what we were thinking about and make it more confident that we're going that way. But there's one curveball. And that curveball, Jimena, is the alkaline phosphatase of 380, very abnormal. So these are opportunities for whenever you're surprised to take a breath and be like, wait, let me think about it completely separately so I don't miss anything. And then let me integrate it. Another fancy word. I don't know why. Today is like fancy word day. But like, how do you think about a high alk phos if that's all you know about the patient? What thoughts come across your mind?
I think that in this case, I'm thinking more that this might be coming from bone because we already got other liver tests and they are pretty much normal. So I think that I would be prioritizing finding if this infection is bone related, or if we can have, for example, like a primary malignancy that we don't know of, and we're just seeing an infection because her immune system is just being compromised due to that malignancy. So that's how I would try to interpret that at this point in time.
Absolutely superb. Uh, it sounds like, I'll summarize what you said, that you think of alk phos as either coming from the liver or bone, right?
Yes,
Awesome.
correct.
Superb. And so you prioritize bone because you expect that when it's hepatic involvement to have other hepatic clues such as an AST, ALT, or bilirubin, which is superb. Now, the hard question in medicine is to actually try to poke the holes in your theory, your own theory, and start to be like, well, where do I go? So if somebody has an alk phos from their bone, the most common clue that it's bone is that they will hurt. A bony alk phos hurts like heck. So the counter to the liver hypothesis is this is alk phos in isolation. An isolated alk phos is characteristic of bony disease because bones don't have AST, ALT, or bilirubin. But bony alk phos is almost always accompanied by pain. Bones hurt like heck. So when you have a metastatic cancer to bone or when you have osteomyelitis of the bone, the patient comes in and they're in pain. And so I don't know. I think it's tricky. I think it's really tricky. Can you think of another blood test that can help you prioritize liver or bone? Have you heard of this nice trick?
No, no.
It's called the GGT. Have you heard of the
Okay.
GGT before?
Yeah, yeah,
And
yeah.
what does the GGT do for you? What do you know about it?
Well, when I think about GGT, I think that it's like a very non-specific enzyme. Like they usually teach you that it's related to alcohol consumption and that
Yes.
there's a million things that can make it higher or can
Yes.
elevate it. So honestly, it's not an enzyme that I put a lot of attention because I know that it's not going to be a specific, but I'm guessing that
No, you're right. I was actually going to make that point. That's exactly right. So, Elliot Tapper, who is a leading hepatologist on Twitter, makes the point that a GGT does not help you understand the nature of the liver disease. And we used to think that it was very specific for alcohol or very specific for cholestasis, but its specificity is very low. However, it still retains the value of prioritizing liver over bone. But within liver, you can't make much progress because the bone doesn't have GGT. But you can't say, oh, GGT, so alcohol, or GGT, so just cholestasis. But you can say, oh, this makes me move a little bit more towards the liver. Um, yeah, I think imaging will be definitive when you image the liver or you image the bone. But to be honest with you, Jimena, I would be much more surprised from a painless bony alk phos then I would be surprised from an isolated hepatic alk phos. So, in other words, not to be so confusing, I would lean more towards this being liver, because it would shock me way more for a patient to have bony alk phos this high without a hint of pain. But good thing we don't need to speculate. Oh, you're going to say something. Go ahead.
I was just going to ask you about the patient mental status because she's confused. Would that swing you away from thinking that she might be feeling pain, but she's not able to express it? Or that maybe sometime in the history she felt pain, but she's not able to articulate it right now?
I think that's a superb question. I actually forgot about how confused she was. And I think that again, like now we're in the washing machine, just tumbling in circles and circles and circles. I think that's a very good point. And one thing that we should incorporate into our confidence about whether she actually has pain or not. That's an excellent point. Sounds like we need more data, but I think what we can agree on is we weren't expecting the ACFOS to be part of this case. And we were just accumulating other things to this disease. First, we started with vision, and then we got brain, and now we got liver or bone or both. And so this picture is getting more and more complicated, but I'm really proud of one thing that you're doing. You're not trying to solve this problem yet. You're trying to understand it. And I think that's a lesson for everybody listening is this exercise is, we haven't mentioned a single specific diagnosis yet, except deadly ones like GCA. And that's what clinical reasoning about is first try to understand the problem and then solve it. And we're still in understand mode. So hopefully Yuki, you can give us more data to help us understand this better.
Okay. We did chest X-ray and ECG, which were within normal limits. And we also did contrast enhanced body CT because we saw this patient in COVID pandemic era. So, and that CT showed right lung lower lobe consolidation and liver cyst. And head CT showed no cerebral hemorrhage, no space occupying lesions, but high density areas with a fluid interface creation in the bilateral ventricles. And head MRI shows no palate infarct lesions, but hyperintense lesions in the bilateral ventricles. At this point, we made a phone consultation because this patient came in the late at night. So we made a phone call consultation with ophthalmology and neurology, but who stated diabetic retinopathy is not an emergency condition, and they denied the possibility of a stroke, and they recommended further investigation to determine the cause of a fever. Finally, she was admitted to the general internal medicine department. I will stop here.
Oy, oy, oy. We have a right lower lobe consolidation, a liver cyst, and bilateral densities in the ventricles. Um, it sounds like two people in internal medicine should tackle this complicated case.
I
Um,
think you were right from the beginning to just suspect that this might be liver because now we have a lesion there. So
yeah.
I'm just really amazed by you, Robbie.
Oh, I don't know. I think that honestly, I was probably 70-30. And so I'm glad that, I mean, it worked out that way, but it's still, especially when the patient was confused, I think the pain thing is, but you can take that when somebody has an alk phos and it's not painful, it's a little bit more likely liver, but it could have played out anyway. Um, so what did this information do for you now, Jimena? What are you thinking?
Um, I think that right now that we're trying to, as you said, understand, I'm trying to just like find something and put together
Mhm.
something that may like involve everything and it might be difficult, but I just have one question for Yuki. Is
Yeah.
this patient from Japan too?
Yes.
Yes. Okay. So one thing that popped into my mind and just
Excellent.
I associate immediately with liver
Mm.
cysts and with the epidemiology of this patient is
Yeah.
just like an infection by Klebsiella pneumoniae. That's
Excellent.
like very common in Asian countries.
Outstanding.
And that could give us like the whole picture of having like the liver cyst, a lung consolidation would be not weird for Klebsiella to pick up the bone. And if we're thinking that this patient was septic and it's just like an infection, that's like one thing that popped right into my mind. But I know that I shouldn't anchor into things because we haven't fully understood the whole problem yet.
Um, Jimena, this has never happened before on VMR, where I believe that the learner picked out the diagnosis out of thin air. Many times in these cases, um, when you've seen them before, you like have a sense of where this is going, and you just keep quiet and my goal is to guide you there. And I was going to spend about 5 minutes to try to guide you and teach you about this diagnosis, but I don't know what to do now. I was outstanding. This case is screaming invasive Klebsiella syndrome. It really is. Um, so I think I would really ask you to do what I was going to do and try to take more time and teach us what you know about this and what is it to just like slow down and zoom in on the details of this syndrome and why you think it's a good fit, because I completely agree with you. I think this is what I would be worried about right now.
Well, first of all, I think that we have like a very good case of saying that this patient might be dealing with sepsis. And one of our initial hypotheses was that this was an infection. It was a little bit reassuring to know that the head CT was normal and that it ruled out stroke, which in my mind was another like big contestant for that. I What I know about this specific pathology is that it is, as I said, it's very prevalent in Asia, and it presents specifically with one or multiple liver cysts. And Klebsiella, even though that being like a negative gram bacteria, it can behave a lot like a gram positive in the sense that it can cause very severe bacteremias, and that's how it spreads all over the body. Um, yeah, that's what I know.
Excellent, superb. Yeah, I think this is a great time to. We don't know if this is the answer or not, but I think that when we said earlier, Jimena, that our job is not to make rare diagnoses, it's to make an argument for why we should change our behavior in certain instances. And we said in the first alquat, we're going to change our behavior to think about GCA, even though it's rare because it could kill the patient and have consequences. We need to change our behavior right now because empiric treatment for Klebsiella is indicated in this patient based on recognizing the syndrome. So how would our thinking change management? You would probably cover this person broadly, but you would need to institute empiric carbapenem coverage in this patient for the risk of this resistant organism when you otherwise would not put a patient coming from the community on a carbapenem. So your management would change. And so it's really important that you recognize the possibility of this syndrome as you did so well. But let me, in addition to what you did, let me sort of paint the most efficient path to recognizing it that I can see. And I'm sure with more experience, you can see it even faster. Whenever you have fever, vision loss, and a red eye, endophthalmitis. The most common cause of endogenous endophthalmitis, meaning it's not coming after trauma, in a patient with diabetes is invasive Klebsiella syndrome. Full stop. When you see that in a patient from East Asia who is diabetic, that is the disease process. Those are the patients who get this disease. And then, Jimena, as soon as the ALK-Phos came back, I wasn't being fully transparent with you. The pretest probability of liver involvement was also influenced by the hypothesis of the most common cause of endogenous endophthalmitis being Klebsiella, and knowing that Klebsiella is characterized by a liver abscess. So, what facts can you take away from this case thus far? Endogenous endophthalmitis, think Klebsiella. Liver abscess, think Klebsiella. And when you see it in a patient with East Asia with this infection, you have to treat it empirically. So this patient would probably, if they presented to one of the hospitals here in the United States after travel, for example, would empirically get a carbapenem when they ordinarily would not. They would probably get ceftriaxone or maybe Zosyn, but the high rate of ESBL, extended spectrum beta lactamase, in this syndrome mandates treatment for it. It is a very morbid diagnosis with many patients having poor outcomes. But Jimena, I think we should also, just for the sake of time, recognize that while it is possible, the patient could have many other things. And I think now we have a diagnosis of ventriculitis. And so the patient would probably be getting broad spectrum antibacterials for all the causes of meningitis, including Staph aureus, strep pneumo, and a carbapenem to cover this organism. Just for the sake of time, is there anything else that you wanted to add before we pass the mic to Yuki for more information?
Yeah, I think that I would ask you, what do you think about getting an LP with this patient? Because
Uh,
we haven't talked about that, and even though the CT was normal, like we can't completely rule out that there is like another infection in the brain.
I think this person has a very high likelihood of having meningitis, not just because of the Klebsiella, but because she has ventriculitis on her CT scan. So her meninges are so inflamed that her ventricles are full of pus. So spontaneous ventriculitis should mandates evaluation by lumbar puncture. And I think this patient would probably get one. So what would be practical next steps? Blood cultures, um, sampling of the eye, which sounds really gross, but is very helpful, and then lumbar puncture. You probably don't need to do all of those to get the diagnosis, but I think in a case as complicated like this, our infectious diseases colleagues like to have as much microbiological data as possible to accurately care for the patient. So I think this patient would first get vancomycin and a carbapenem, like ertapenem or meropenem, and then we would proceed to getting we would get the culture data first. Sorry, we'd probably get blood cultures first, eye cultures quickly, and then antibiotics, and then an LP. I don't think I would wait for the LP to give antibiotics. This person's too sick. All right, Yuki, tell us more, please.
Okay, how do you know my plan? Okay, we also did lumbar puncture, which showed cerebral spinal fluid showed cloudy appearance. Cell count was 10,700. Polynuclear cells 80%, mononuclear cells 16%, protein 400, glucose 60, IgG 50, ADA 14, lactate 100. And yeah, and we also took 2 sets of blood culture. And finally, based on the cerebral spinal fluid test results, bacterial meningitis complicated by endophthalmitis and ventriculitis was suspected. And after admission, the blood culture results showed Klebsiella pneumonia with positive string test. And based on these results, we consulted with neurology again in the daytime. And finally, the diagnosis of invasive Klebsiella infection was made. Amazing.
Wow, Jimena, you did it. How did it feel?
Um, I feel I feel like I'm still processing everything. There's definitely a lot of learning here from me. I
Yeah.
think that eye cases are hard because usually we don't get a lot of training when it comes to the eye. But I want to say thank you to Yuki because actually I got to know this pathology by listening to a podcast, and I never thought that I would see a case of it. So thank you very much for bringing it. It was really cool.
Yeah, I love how at first you're like, oh, I don't think I've ever seen endophthalmitis before, and here you are now having seen it and seen it from caused by something you're familiar with. I'm really, really glad to see that. I think as we emphasize, this is not about getting the diagnosis right. It's about knowing the journey. But I think that when you've worked so hard to understand medicine to the depths that you've worked hard to, it's nice to be able to celebrate being able to effectively and efficiently take care of a patient because of your hard work. So kudos to you for recognizing the syndrome. But I think more impressive and more important to celebrate is your desire to take your knowledge further and to understand things like the eye that you don't understand as well as you want to. And hopefully one day you'll understand endophthalmitis as well as you understand Klebsiella. And knowing you, I'm sure you'll get there very, very soon. Yuki, thank you for an amazing case. I think presenting a case like this, as complicated as it was, with basically 5 sentences or 6 sentences per aliquot, as you did today, just goes to show that you recognize what's the important part and what's not important. And you really made it a very rich conversation today. Very, very grateful for you. What did you learn from taking care of this patient, Yuki?
Uh, Actually, first time I saw this patient, different. Um, I had no idea what to do. So Yeah, and after I saw this patient, I learned, yeah, Klebsiella sometimes cause serious infections, especially with hyperviscosity Klebsiella. Yeah, so this case was really amazing case for me too, because I learned a lot about infectious diseases. So yeah, your discussion was really yeah helped me to learn more about infectious diseases. Thank you so much.
You're too kind, Yuki. It's always a pleasure when you join us, and I know that you're many hours ahead of us in the United States and Japan. So thank you for accommodating our schedule to join at this time. We're very, very grateful for it. All righty, Shreyas, it's 3:30 a.m. in India, but it's time for teaching points, my friend. I can't believe I can say that. Take it away, Shreyas.
Sure. Okay, thank you for this wonderful case, and Himina and Dr. Rabih, wonderful discussion. I learned so much. So we had a patient who came in with sudden vision loss, and when we're dealing with sudden vision loss, it's important to first prioritize the time course and also the localization. For example, in our patient, we had a unilateral vision loss, so it's important to make that differentiation whether it's unilateral versus bilateral, and also Dr. Rabi mentioned a very nice point about whether we're dealing with visual loss versus visual field deficits. That's something which is important to consider. And when we're dealing with sudden onset vision loss, a couple of things come to mind reflexively. Glaucoma, which is hard red eye, what is something which we should always consider, and ischemia and thrombosis considering central retinal artery occlusion and central retinal vein occlusion. And also, we can also think of optic neuritis and tumor, retinal detachment. And as we keep going towards the posterior eye, vitreous hemorrhage is also something which we need to consider. And when we had the patient who had diabetes, which was uncontrolled, and Dr. Rabi mentioned that the most common cause of monocular vision loss, especially in diabetes, is atherosclerotic disease, which can then embolize and present with sudden onset visual loss. And when we're also considering diabetes, it's also important to note that they can have proliferative diabetic retinopathy and neovascularization, and those vessels can actually bleed and also result in vitreous hemorrhage. And so we had the patient who presented with fever and vision loss. And so we were trying to prioritize an infectious and vascular etiology. And Dr. Abi also mentioned that when we're dealing with vision loss, especially in someone who's greater than 50 years, it's very important to consider the diagnosis of giant cell arteritis because prompt administration of steroids is going to be curative in that scenario. And a very interesting thing which I learned was when you were dealing with chronic uncontrolled disease, we need to sometimes even question the accuracy of the history of presenting illness because the patient could have been actually presenting, would have possibly a chronic underlying process and might have delayed when the person wanted to seek care. And so we might actually be dealing with an acute and chronic presentation. So that was something interesting. And we had the patient who also had hypertension. And so when we are trying to tie in hypertension along with ocular manifestations, uh, we tend to localize it to the retina. So it's not something which would manifest with a red eye or something which we can actively catch on physical exam. And so in that context, dilated fundoscopy becomes extremely crucial. But then when we do actually have the red eye and there are manifest ocular symptoms on our physical exam, it helps us to localize to the cornea, conjunctiva, and sclera. And in the context of red eye and fever, endophthalmitis is also a diagnosis which we should never miss. And when we're talking about infections in and around the eye, it's also important to get imaging for the sinuses to make sure that there's no direct extension of sinus infection into the eye. As we kept progressing through the case, we also noted that our patient had an elevated alkaline phosphatase. And then it becomes important to consider what is possibly causing the elevated alkaline phosphatase. Is it bone disease or is it liver disease? And in that context, it's always useful to get a GGT, but it doesn't really it helps us clue us into the cholestatic liver pathology, but it's not always going to be that. So that's also something we can keep in mind. So our patient clearly had sepsis, and in the context, tying the whole clinical picture together in the context of imaging, which showed liver abscess and lung consolidation, and also a lumbar puncture, which ultimately showed evidence of bacterial meningitis, and also taking into consideration the fact that she had uncontrolled diabetes and also the Southeast Asian demographic. So putting all of this together, Himina made a wonderful diagnosis of Klebsiella invasive syndrome, which was the leading hypothesis as we came to the end of the case and was ultimately the final diagnosis. And it's important to start these patients on empiric carbapenem therapy.
My God, I can't believe you did that so well, let alone at 3:30 a.m. That was unreal. Thank you for emphasizing all the salient points and actually reminding me to shed light on that teaching point about being more flexible with your HPI's accuracy when a patient has chronic uncontrolled disease. And now recognize this patient had pneumonia, had meningitis, and had a liver abscess. There's no way that this has been going on for just 3 days. Much, much longer than that to develop a liver abscess at least. So I think that point, thank you for emphasizing it. And I'm glad this case reinforces that. And as Jimena said, the gaze broadened and broadened and broadened as we got more and more data. But suspecting that from the get-go based on the uncontrolled diabetes might have made you seen that even sooner. Anyway, enough of me babbling away. Amazing job, Jimena. Yuki, thank you so much for a great case. And Shreyas, rock on, my friend. Hope you get some sleep. And gratitude to Navpreet for scribing away a very complex case. Hope to see you all tomorrow for student VMR. Bye.
Bye. Thank you.